Hello, everyone. This is Hassan, International Clinical Application Specialist for Mandre in Africa and Middle East region. And today we will conduct another CME ultrasound course session working with the Radiology Society of Ethiopia. Well, the goal of this series, as the name suggests, is continuing medical education, a way that we can facilitate to have a continuous educational activities to increase the skills and the professional performances of sonographers, physicians, and also to build a lifelong relationship. As what is on our agenda for today, we will have the opening speech from one of our well-respected doctor, the head of RSE. Then we will dive into our main topic, which is the evaluation of carotid lesions with duplex ultrasound by Professor Bouayed from Algeria. And at the end, make sure you put your questions, if you have any, at the chat box. We will have time for Q&A session at the end. But first, let's welcome Dr. Masfin Mulugeta to give us a brief opening remarks.
Hello everyone, I'm Dr. Masfin Mulugeta, radiologist, musculoskeletal radiology fellow at Addis Ababa University, president of Radiological Society of Ethiopia. I'm here to invite you to one of our CME organized by RSC in collaboration with Mindre. As you know, Mindre is by the side of RSC whenever there is any need, and currently they are planning as many CMEs as possible, which are ultrasound related. And this time, our current CME is on duplex ultrasound of extracranial circulation, mainly focusing on carotid duplex ultrasound. My brother from Algeria, Professor Bouayed Mohamed Nadjib, will give us a presentation. Professor Bouayed Mohamed Nadjib is a professor of vascular surgery, former head of vascular surgery department of Oran University Hospital at Algeria. He is a member of the French Academy of Surgery, president of the Oran Vascular Surgery Association. So hoping that you will enjoy from his presentation and you will benefit a lot from his ample experience and knowledge. I will invite Professor Bouayed Mohamed to the stage. Enjoy his presentation.
Hello. First of all, I want to thank you for the invitation, and I will present to you the evaluation of carotid stenosis with duplex ultrasound. I am going to do a little anatomical reminder. You see in this figure, in this picture, the venous network of the superior vena cava, and behind the venous networks, you see the arterial trees. And you see here the internal jugular vein close to the carotid common artery. You see here the subclavian vein, the illuminate vein, the right, and the left illuminate vein, the left subclavian vein, and the left internal jugular vein. And in the second picture, we remove the systemless veins, and you see here the vascularization of the brain. The illuminate arterial trunk, which is retrosternal, the first branch of the aortic arch, and which then divides into a subclavian artery, which supplies the upper limb, but which provides an important branch for the brain. This branch is the vertebral artery. The right common carotid artery is the second branch of the illuminate artery, later in relation to the sternocleidomastoid muscle, which divides at the top of the neck into the external carotid, which gives collaterals which vascularize the face and these muscles, and whose flow is resistive. And the second artery is the internal carotid, which perfuses the ipsilateral cerebral hemisphere, which is in low resistance. The initial segment of the internal carotid, named bulb, is dilated and flared, and it is the preferred site of atheromatous plaques. The second artery of the aortic arch is the left common carotid, artery, which also divides into the external and internal carotid artery. The third branches of the aortic arch is the subclavian artery, which gives the left vertebral artery. The left vertebral artery have 4 segments. There is V0, the ostium of the vertebral artery, originates from the subclavian artery. Then there is a segment V1 in the neck, and then the vertebra enters the conjugation holes of the cervical vertebrae from C6 to C2. From here, it exits to go into the occipital foramen, forming the vitreous segment, then enters the skull to form the V4 segment, which joins the V4 segment of the contralateral vertebral artery to form the basilar trunk. The terminal arteries of the internal carotids and the basilar trunks anastomose among themselves to form the circle of Willis. But you see here the innominate trunk, the common carotid artery, the right, the internal carotid artery here, the external carotid artery here, the subclavian artery, the subclavian left artery, the common carotid artery, the left, and divided into internal carotid artery and external carotid artery. And you see here the vertebral arteries, here, and here. There is here the V0, the V1, the V2, between the bones, the V3, the V4, before the skull, and in the skull there is the V-cut, V4, and the V4 and V4 join us to form the basilar trunk. What are the indications for carotid duplex? Carotid duplex, it's important to search thrombosis, the carotid thrombosis, to evaluate arterial stenosis in a patient who had a stroke or a transient ischemic attack. If it's felt in the neck a murmur, if we suspect a carotid or vertebral dissection, to evaluate Takayasu disease, and to follow a patient who has undergone a carotid endarterectomy. What are the limitations of carotid duplex? Carotid duplex is limited when the neck is thick and chunky. But for this patient, we must use the probe, the transductor of low frequency between 33 and 5 megahertz. And you can, with this probe, evaluate with little precision the arterial vascularization of the neck. Another limitation is calcium deposits in the carotid walls that cause shadow cone that not allowing visualization of the carotid wall. And when there is low echogenic plaque, it's possible that we can not be detected. And also there is difficulties when the carotid bifurcation is high in the neck. Here are the normal B echo imaging of the carotid common artery. And you see here the wall structure that has the characteristics of double reflection with an hypoechoic zone lying in between these two. This hypoechoic zone is named the intima media thickness. The hyperechoic zone here corresponding to the adventitia of the artery. And here you are the lumen of the common carotid artery, and here this hypoechoic zone is the intima media thickness. What are the decision making for the prevention of stroke? It's important to manage the patient with a carotid stenosis, to calculate the degree of stenosis, to analyze the plaque morphology, and to analyze the patency of intracranial collaterals, especially circle of Willis. circle of Willis, whether or not circle of Willis is complete. The pulsed Doppler cursor in the evaluation of the hemodynamic and the anatomic evaluation of carotid lesion must be at the stenosis, at the end of the stenosis. The incidence angle of the ultrasound must be between 40 and 60 degrees. And you must also do an angle correction with the angle corrector that you find it in the machine. The slider, the sampling window of the pulsed Doppler must cover the entire carotid artery. The pulsed Doppler cursor should be positioned just at the end of the stenosed region. The angle correction is important. The correction cursor will be placed parallel to the circulatory direction. The pulsed Doppler cursor must cover all the arterial bone. Hemodynamically significant stenosis is diagnosed primarily through the measurement of markedly elevated flow velocities using spectral Doppler, one component of carotid ultrasound, in the narrowed portion of the internal carotid lumen. The increase in velocity is proportional to the severity of the obstruction. To diagnose stenosis, measurements of the peak systolic velocity, PSV, is important. And the secondary parameters for quantifying stenosis include end diastolic velocity, internal carotid artery to common carotid artery ratio, and the presence of plaque of B-mode imaging. Other factors to consider when interpreting studies include the presence of calcified plaque, which are the origin of an acoustical shadowing. They may limit visualization of the walls. Also another factor is the contralateral high-grade stenosis, and also another factor is the kinking or bands in the vessel, which may forcibly elevate the velocity. So when you have a PSV of more than 210 centimeters per second, it's linked to a stenosis more than 70%. When the systolic peak systolic velocity is more than 250, is linked to a stenosis more than 80%. A stenosis more than 70% in symptomatic patients will consider the operation, the surgical intervention in the patient. And when in a symptomatic patient, you find stenosis more than 80%, and when the life expectancy of this patient is more than 5 years, and surgery, an endarterectomy or an angioplasty will be considered. When the systolic ratio is more of the 3, and diastolic ratio more of the 3.3, this is linked to a stenosis more than 70%. For example, if you have at the end of the stenosis a PSV at 300 centimeters per second, and you have at the same time in the common carotid artery PSV at 100 centimeters per second, and you have a ratio of 3, and the ratio of 3 is linked to a stenosis greater than 70%. And you can also calculate the degree of stenosis by the diameter using longitudinal sections and using methods of NASET and ECST, or you can calculate the degree of stenosis by surfaces and using cross sections, and you use also the method of NASET or ECST. I will talk to you about this later. The morphological plaque study is very important to search a high neurological risk in a patient. The plaque morphology is important. The information about its plaque morphology identifies plaque vulnerable to disruption and atheroembolization, leading to a better calculation of an individual's risk for stroke. The recognition of vulnerable plaque is important in the surgical management of carotid arteriosclerosis, especially when CAS is considered. CAS is carotid angioplasty. Carotid plaques with a large lipid core and thin fibrous cap are more likely to rupture. And also the large pressure gradients across the stenosis can influence plaque by increasing the wall shear stress and causing cap disruption. And you can also visualize a thrombus on a plaque. So there is embologenic criteria that complex, crevice, heterogeneous plaque, that anechoic lesion in a plaque linked to a subintimal hematoma, and also the presence of a thrombus. The plaque characteristics is very important, and the composition and echogenicity of this plaque must be evaluated. And homogeneous and hypoechoic plaque and heterogeneous and hyperechoic plaque are calcified with posterior acoustic shadow cones. You must study the surface of the plaque, regular, smooth, irregular, swampy, ulcerated. And you can also found an hypoechoic lesion within an echogenic lesion. So in this case, you can say that there is an intraplaque hemorrhage. You also can see a niche that linked to the ulceration of the plaque, and the plaque can be smooth, calcified, or uniform echogenic plaque, little threatening. So I said that in symptomatic patient, when the degree of stenosis is more than 70%, the indication of an operation is important, and it's considered. But between 50 and 69% of degree of stenosis, it's important to identify a patient at high risk of neurological problems of stroke. In fact, the NASCET study, NASCET is a North American study carotid endarterectomy trial. It's a big trial made in the United States during the years 1990. The NASCET study definitively underlined the indication of carotid revascularization in symptomatic patients with a stenosis of more than 70%, but for patients with a stenosis between 50 and 69%, it will be necessary to identify a subgroup of patients with a high neurological risk. And for this purpose, the study of the morphology of the plaque is important. Plaque morphology includes surface, smooth versus irregular, and structure, homogeneous, heterogeneous, hemorrhagic, calcified, ecolucent. These characteristics of the plaque is very important. Certain plaque characteristics can affect patient outcomes. For example, ecolucency within a carotid plaque correlates with the presence of lipid component and is associated with increased neurological events, as are plaques that are heterogeneous and or irregular as opposed to smooth and homogeneous plaque. This is a notable concern in carotid angioplasty, since plaque is not removed, but rather pushed to the side. And the study imaging carotid types 1 and 2 are at high risk of stroke. You can see here normal arteries. You see here the inguinal artery, the subclavian artery, and the carotid, the common carotid artery. Slide. You see here a normal carotid common artery with a color Doppler, which completely and uniformly fills the lumen of the carotid common artery. You see here also a normal carotid common artery and the spectral curve with a diastolic flow above the baseline, because the brain is at a low resistance, and you have a diastolic flow in the common carotid artery. And you see here a common carotid artery in a cross section, and it's a common carotid artery which is normal. You see here a little short video of this common carotid artery with the power Doppler. You see here also another picture of an internal carotid artery. It's here, the common carotid artery, it's here, and the internal carotid, it's here. And you see here a little plaque, an isoechoic plaque in the bulb of the internal carotid artery. And you see here the diastolic flow of this internal carotid artery, because internal carotid artery perfuses the brain, the hemispheric ipsilateral of this internal carotid artery. You see here the angle corrector, which is placed parallel to the blood circulation. You see here also an internal carotid artery, but distally, distal internal carotid artery, the bulb is here, and the distal carotid artery is here, and the spectral curve with a diastolic flow and a diastolic flow. You see here also with the E-flow, the power Doppler, the internal carotid artery, the bulb flared, little dilated. You see here also another picture of the bifurcation of the carotid artery. And you see here that the color fully, completely fills the arterial lumen of the internal carotid artery. And here you see the external carotid artery with these first branches of the external carotid artery named superior thyroid artery, with the internal carotid artery haven't collaterals, but carotid external artery have a lot of collaterals, and there is a criteria to differentiate internal carotid artery and external carotid artery. And in the internal carotid artery, the flow, the diastolic flow is above the baseline, but in the internal carotid artery, there is no diastolic flow. The spectral curve is similar than a spectral curve of the members. You see here also a bifurcation of the common carotid artery with a little plaque and thickness of the intima media. You see here the spectral curve of this internal carotid artery, and you see here the external carotid artery. The other slide, you see here the same thing in internal carotid artery with the spectral curve at the right, And you see here, it's important, the external carotid artery, the internal carotid artery, and you see here the bulb. The bulb is flared, that I said. And there is sometimes in this bulb two different colors. It's not normal. It's there in this picture, you see a blue color and a red color. This blue color is linked to the flow turbulent, the turbulence of the flow in this flared segment of the internal carotid artery, named bulb. You see here also this, the bifurcation of the common carotid artery, and this little zone in red linked to the turbulence of the flow in this segment, a little dilated of the bulb of the carotid, the internal carotid common artery. You see here another picture. You see the internal carotid artery, the common carotid artery, the external carotid artery, and the superior thyroid artery. It's the Doppler used here is the power Doppler. Another picture, the same, with the superior thyroid artery. And here you see a band of the internal carotid artery. And when we put the cursor of the pulsed wave in the top of this band, we have in the spectral curve and high velocity and a peak velocity, peak systolic velocity relatively higher. And you have also a high diastolic flow. This is a normal spectral curve, and you must do the difference between stenosis and band and loop. In a band, the color completely fills the arterial lumen, but when there is stenosis, the color fill the narrowed artery, also the patent lumen, not like this band of the internal carotid artery, which is filled by the color Doppler. You see here the subclavian artery, the V0, the ostium of the vertebral artery, and here you see the first segment of the vertebral artery. Here you see the distal portion of the vertebral artery in his V1 segment outside the vertebral bone. This is shadow is the vertebral bone. And you see here the V2, the segment V2 of the vertebral artery between the shadows of the bone of this cervical vertebrae. Here is a cervical vertebrae, C6, and here C7. You see here between these two bones, the vertebral vein, and after you see here the vertebral artery. Another photo, you see the segment V2 of the vertebral artery. Here is the cervical vertebrae, and you have also the spectral curve, and also in the vertebral artery there is a systolic flow and also a diastolic flow above the baseline, because vertebral artery perfuses the brain. The brain is have low resistance. Here you see also another picture of the vertebral artery. You see here also another picture of the vertebral artery, the left vertebral artery, and you see the shadow of the bone. You see here a subclavian artery, and you see the spectral curve of this vertebral subclavian artery, similar to the spectral Doppler of the members, with a systolic peak and no diastolic component, because vertebral subclavian artery perfuses the member, and the member is at high resistance. So when an organ is at high resistance, there is no diastolic flow, as we show in the internal carotid artery and in the vertebral artery. You see here a small moving plaque, dangerous, because it will come off and embolize. It will come off and embolize. And you can see here this plaque molded by the energy Doppler. There is a short video. You see this plaque molded by the color of the power Doppler. Another plaque here. You see an isoechoic plaque in the carotid bulb, the spectral Doppler with peak velocity, systolic velocity, and a high. So you see here an isoechoic plaque, and this plaque is smooth. Another picture, you see here also a smooth plaque with a regular surface in the bulb of the internal carotid artery. You see here also a band of the vertebral artery and a color that filled all the lumen of this vertebral artery. And you have in the spectral Doppler high velocity of the systolic flow and the diastolic flow. You see here a big calcified plaques of the internal of the carotid common artery. See here. Difficult with these plaques to evaluate the walls of the common carotid artery. You see here also a very calcified plaque and the shadow cone of this carotid plaque, and the difficulties to evaluate the carotid walls. You see here also two big carotid calcified carotid plaques and the shadow cones of this plaque and the cone of this plaque, the shadow cone of this plaque. So, to calculate intima media thickness. The intima media thickness is the distance between two lines separated by a hypoechoic band seen in 2B echo of the deep wall of the carotid common artery, 2 centimeters before the carotid bifurcation. You can use the manual method, but the best is the automatic measurement. How to measure the intima media thickness? A line is drawn on the internal hyperechoic line, and another line is drawn on the external hyperechoic line. And you have between the two lines the intima media thickness, and you can calculate the intima media thickness by this method. It's an easy method to calculate intima media thickness. The intima media thickness is normally of 0.7 millimeter between 50 and 60 years old. Intima media thickness increases by 0.01 millimeter per year, and IMT is higher in man. IMT is predictive and an element of cardiovascular events. And when there is a 0.1 millimeter increase in IMT, the risk of myocardial infarction is about 5.6%. Here are the normal values of the intima media thickness originates to the Plaque studies published in 2003. And you see that the woman's IMT is lower than that of the man. You see here the method to measurement of the degree of stenosis by the ratio of the areas. This is an unprecise measurement, but you can do it. When you press the measure by area button, you will have an ellipse that will appear on the screen, which allows you to identify the outline of the arterial, artery in cross section. And another ellipse allows you to identify the patent lumen. As you see here in this picture, the patent lumen is here, and the arteriomatous plaque is here. And after, you will calculate the ratio between the two, and therefore the degree of stenosis by the method of measuring areas. But the better method to measure the degree of stenosis is the calculation by the diameter. The calculation of the degree of stenosis by the diameters is more precise. Symptomatic patients presenting with a neurological event, such as transient ischemic attack, or stroke, or amaurosis fugax, form the basis for such well-known studies as the North American Symptomatic Carotid Endarterectomy Trial, NICET, and the European Carotid Surgery Trial, ECST. The NICET trial demonstrated a conclusive benefit for carotid endarterectomy in patients with symptomatic 70 to 99% internal carotid artery stenosis. NICET was established by a geographic calculation of IC stenosis percentage using the following formula. You calculate, you have to calculate the diameter of the patent lumen, here the plaque, the stenosis zone, the patent lumen. You must calculate this, the diameter of this patent lumen, named A, and after you go to the internal carotid artery, a normal carotid artery with parallel walls, and you do the ratio A minus B, and you have after the degree of stenosis. So I repeat the NICET formula to calculate the degree of stenosis of the internal carotid artery. The percentage of internal carotid artery stenosis is the ratio between the narrowest internal carotid artery diameter on the diameter normal distal cervical ICA multiplied by 100. So it's B minus A on B multiplied by 100. An example, if you have the patent lumen at 2 millimeter and the normal lumen of the carotid, the internal carotid artery at 10 millimeter, and so you have a stenosis of 80%. The Nasset method is the best method to calculate degree of stenosis. There is another method, in the ECST method, the European method, and you can calculate by this formula. ECST was established by a geographic calculation of internal carotid stenosis percentage using the following formula. The diameter of the most stenotic part of the bulb and the estimated original diameter at the site of stenosis. So you have the diameter of the patent lumen and the diameter of the bulb, the first portion of the internal carotid artery in the site of the stenosis. And you have this formula, and you have the degree of stenosis. An example, if you have diameter of the patent lumen at 5 millimeter and the diameter of the bulb at 15 millimeter, so you have a stenosis of 75%. The calculation of the stenosis by ECST is estimated. Nasset is the best method to calculate the degree of stenosis. I show you this photo, and you see here the plaque, the patent lumen, the narrowed artery. To calculate by ECST, you must have the diameter of the bulb and the diameter of the patent lumen, and you use the formula that I have shown you in the last diapo. To calculate by Nasset method, here you have the bulb, you have the plaque here, and here you must have the diameter of this patent lumen and the diameter of this patent lumen in a normal zone of the internal carotid artery, and you do this minus this, multiply 100, and you have the degree of stenosis. You can see here also another picture. You see the bulb of the internal carotid artery, the plaque, the patent lumen, the narrowed artery, the spectral Doppler, and you see here that the cursor is here in the stenosed zone, and you see that in the spectral Doppler there is a systolic velocity, the peak systolic velocity is here, and the end diastolic velocity is here. So there are criteria to. So as I said before, velocimetric measurements are the most accurate for calculating the degree of stenosis. The Doppler volume will be placed very close to the stenosing plaque. Angle correction and adjustment of the PRF, the pulse repetitive frequency, must be made, and you have in the machine the PRF, the pulse repetitive frequency. When the velocity is higher, you must increase the PIRF, the pulse repetitive frequency. And after you have the criteria of carotid stenosis. This is the criteria when an internal carotid stenosis is greater than 70%. When you have a systolic peak velocity greater than 210 centimeter per second, and end diastolic velocity greater than 70% centimeter per second, when you have a carotid systolic ratio greater than 3 and a carotid and diastolic ratio greater than 3.3, you have with this criteria an internal carotid stenosis greater than 70%. You have I show you a short this photo, the same photo that I showed you before. You have the plaque, the plaque here, and the patent lumen of the internal carotid artery. It's the same another patient with another photo, the stenosis of more than 80% of the internal carotid artery with velocimetric measurement. You see here the cursor of the pulsed wave at in the stenosis and the spectral Doppler, and after increasing the PRF, the pulse repetitive frequency, you see that the peak systolic velocity is not visible. To visualize the peak systolic velocity, you must increase more the pulse repetitive frequency. But in this case, you can see that the peak systolic velocity is greater than 250 centimeter per second. And you can say that the degree of stenosis of this internal carotid artery is more than 80%. You see here an equivalent plaque with the patent lumen here and with the internal carotid artery. You see here also in the common carotid artery a plaque here in the common carotid artery, but a non-stenosed plaque. And you see also here stenosis, but moderate stenosis of the common carotid artery with a peak systolic velocity at 150 centimeter per second. So a stenosis of 50% and not more. You see here a very tight stenosis in the Doppler color, and you see that the color molds all the plaque. I show you another time this case, this photo, and you see here the patent lumen and the narrowed artery. You see here the common carotid artery and the bulb of the internal carotid artery. Another patient, another photo. You see here the same case, but with the spectral Doppler, and you see that the peak systolic velocity is higher than 400 centimeter per second. So this stenosis is very tight. It's a very tight stenosis of internal carotid artery. I show you once again this picture and the spectral Doppler at the right. Another photo. You see here this also very tight stenosis of internal carotid artery, and you see this turbulent flow with no peak systolic velocity. You see this photo and this Doppler. It's the mode power Doppler. And you see here a very interesting case of a patient that was in our hospital that had a stroke, and when we used the pulsed Doppler, there was no signal in the internal carotid artery. And when we used the color Doppler, the normal color flow Doppler, there was no color here in the internal carotid artery, but we used another mode of power Doppler named E-flow. This mode of Doppler improves the morphological analysis of lesions, allows, thanks to the improvement of the spatial resolution, to opacify without overpainting circulating channels less than 5 millimeters of diameter. This E-flow allows a new approach to vascular anatomy and maintains very good sensitivity in the detection of slow flow and of narrowed artery. With the color Doppler, I thought of an occlusion of the ICA, and therefore that there was no operative indication. But using the E-flow, a fine channel was visualized, and therefore it was a very tight internal carotid artery stenosis. And this patient had an carotid endarterectomy. I will show you this case. You see here this the E-flow, the color of the E-flow that go in this very little channel. Show you a short video, and you see here this the color of the E-flow through this very tight patent lumen of the bulb of the internal carotid artery. I show you once again this case. You see here also a very tight stenosis of the internal carotid artery. You see here turbulent flow, and mosaic color, and you see that the systolic velocity is higher, and the diastolic velocity is high also. You see here also a very tight stenosis, but of the external carotid artery without flow after this stenosis. Is a pseudo-occlusion of the external carotid artery. Another case here, you see also this very tight stenosis, this little patent lumen, the plaque here, and you see also a little anechoic zone in this plaque. So there is a little hemorrhage in this plaque. I show you once again, and you can see this little anechoic zone on the plaque. The same patient, but with the pulsed wave, pulsed Doppler. And you see here in the spectral Doppler that there is a turbulent flow, and when pressing the key of the pulse repetitive frequency, the PRF, and increasing it, we get to have the systolic peak and to calculate the PSV on the velocity scale. The velocity scale is here, which is to the right of the spectral curve. Show this, and show this, and I calculate this degree of stenosis by pressing the PRF, the precipitative frequency key. You see here also another case of stenosis, more than 80%. The peak systolic velocity is at 300 centimeters per second, like you see here in this scale of the velocity. And you see also an ulcerated plaque with a visible niche here. I show you once again this photo. Here you see a significant stenosis of the vertebral artery in his distal segment of the segment 1 of the vertebral artery, and you see the increasing of the velocity when the cursor of the Doppler was put in the stenosis, and when the corrector angle was put also parallel to the flow circulation. I show you the video of the pulsate wave of the spectral Doppler of this patient. Another case, you see here an occlusion of the internal carotid artery with no flow, with the images of thrombus in the lumen of this internal carotid artery. You see here the common carotid artery, and here the internal carotid artery. Another case with using the E-flow, and you see here the common carotid artery and this fibrous internal carotid artery, hyperechoic and fibrous. I show you the video of this case, and you see here the E-flow blocked in the origin of the internal carotid artery. Internal carotid artery is here and occluded. You see here another big plaque in the common carotid artery. And you see here a case of Takayashi's disease. Takayashi's disease is an inflammatory disease. And you see here in this photo the circumferential, homogeneous, and inflammatory thickness of the walls of this carotid common artery. Another photo of Takayashi's disease. Also, you can see the thickening of the walls in a woman that had 35 years old. Another photo, longitudinal sections. You see here the circumferential and homogeneous thickening of the walls. I show you a video of this case, and you can appreciate the thickening of the walls. And the same patient, but in the cross section, and you see here the walls of the common carotid artery and the thickening of these walls. Another case. Here I show you an interesting case of glomus tumor. The glomus tumor develops from the glomus cells that are on the carotid bifurcation. The tumor strongly adheres to the adventitia of the internal carotid artery and the external carotid artery, which it pushes aside. The tumor is hypervascularized by the collaterals of the external carotid artery. Like you see here, this tumor globus, tumor, the common carotid artery, and the external carotid artery. I will show you another photo. Same case, and you see here in cross section the globus tumor and the common carotid artery. And you see here with the E-flow, the vascularization of this tumor by the collaterals of the external carotid artery. I show you the video, and you can see the collaterals which vascularize this hypervascularized tumor. And another, once again, another time, and you can see the high velocity of the flow in this spectral Doppler. You see here an aneurysm of the internal carotid artery. You see here the walls of in cross section of this carotid artery, the thrombus here, and the lumen here. Pseudoaneurysm of a common carotid artery in a patient who had a Bouayed disease, an inflammatory disease. You see here the thrombus, and the flow exits from the common carotid artery here. The same case, but using the power Doppler. Another case, aneurysm in a patient who had an endarterectomy of the internal carotid artery closed by patch, and you see here the aneurysm under the patch of the disease zone operated by endarterectomy. You see here the follow-up of a patient who had undergo angioplasty, carotid angioplasty, and you see here the hyper echogenicity of the stent metal, hyper echogenicity of the stent metal in longitudinal section, and in cross section, the hyper echogenicity of the metal of the stent. Another case, the same case, showing a patent stent, the precolor filled the lumen of the internal carotid artery. Another case with the stent in the common carotid artery and in the internal carotid artery. I show you the video of this stent. It's a patient that's treated by angioplasty stenting of very tight stenosis of the internal carotid artery, and the same patient with this stent, as you see in this photo, and after the patency of the stent, and you can see the color Doppler here filling the lumen of the stent. Color Doppler, lumen of the stent. And that, the same patient. Okay, I finished. I apologize because I have not a perfect English, but I hope you have understand what I said, and thank you very much for your attention.
Thank you so much, Professor Bouayed and Mohamed, Nadjib, for your insightful topic. Now we will move on to our Q&A session. If you have any questions, like we said before, please share with us in the chat box or send us an email.